Bismillahirrahmanirrahim. I am Dr. Ehmer, ex-in charge Burn Center Civil Hospital. I'm consultant plastic surgeon, but as far as my practice is concerned, I was in charge of Burn Center, and the fluid replacement is a major component of the treatment in burn centers. That's why I am telling you today about the IV fluids in common medical practice, how to use all these fluids. First of all, I will introduce you those fluids which are used in medical practice and what is their composition and what are their indications, where to use. Let's start with where we are using the IV fluids in hospital or in clinics. Every doctor must have a proper knowledge of these fluids, not only the doctors but also the paramedical staff must know about each and every fluid which they are infusing to the patients. Who are the candidates of fluid replacement? Those patients who are in shock, like hypovolemic shock. The most important in hypovolemic shock is the patient of vomiting and diarrhea, a patient who is suffering from burn injury or accidents, and those who are not, those who cannot get blood transfusion immediately. The volume must be replaced or volume must be compensated by giving these fluids initially till the arrangement of the blood products, blood or blood products. Just in order to provide or to compensate the total volume of circulation. The other important is there are other types of shocks also in which the fluid replacement is needed, but hypovolemic shock is the most important one where these fluids can compensate the deficiency of the volume, deficiency of the circulating volume. The other indication is for administration of the medicines, because there are so many medicines which must be given to the patient in diluted form. In order to give medicine in diluted form, you must need these fluids, and also prolonged time is needed to administer these medicines. There are many medicines, especially the medicines used in ICU patients. Many medicines they need to give them for 24 hours in diluted form. And electrolytes, replacement of the electrolytes, how we can replace the electrolytes if patient is having deficiency of electrolyte. For example, in heat stroke, diarrhea, vomiting, even in burn, you must need and etc. You must need electrolyte replacement. Through these fluids, you can replace the electrolytes. You cannot give electrolyte straight away to the patient through IV. You must need fluids in which the electrolytes are present, and these can be infused to the patient in order to compensate the deficiency. And blood products, as I told you, blood transfusions through these blood products, and also the diagnostic reagents like dyes can be given through IV administration along with the fluids in diluted form, or these fluids can be given after the giving of the after receiving these dyes in order to wash out the circulation or the organs through which these dyes are passing. And lastly, the maintenance therapy. As a maintenance therapy, patient is not taking anything by mouth. He is not taking any water by mouth. He cannot take those patients who are in he cannot take due to some diseases like mouth cancer, or he's totally unconscious. Patient is in coma. He cannot take fluid by mouth. So these types of patient must need maintenance fluid where losses are not there. If losses are there, you must need the maintenance as well as fluid to compensate the deficiency of the electrolyte and to correct the deficiency of the fluid also. And the correction of nutritional status. Correction of nutritional status through parenteral nutrition, that is called as parenteral nutrition. When enteral nutrition, the nutrition by mouth is not possible, you must need solutions. There are so many solutions which can provide the nutrition support to the patient by IV line or intravenous pathway. That also contains all the electrolytes and the protein, fat, and carbohydrate in order to meet the requirement of the patient. These are also the candidates which are present in ICUs. Now come to the components of fluid and electrolyte therapy. As I told you, two types of indications: maintenance or replacement. In maintenance, you have to give the patient a daily requirement of the electrolyte, daily requirement of the water, daily requirement of the nutrition, carbohydrate, fat. If you are giving to the patient, these are the patients which are in ICU, they are in coma and don't have any extra losses. And the replacement therapy in which losses are there, like patient is vomiting, continuously vomiting, he is losing his water and electrolyte also, you must need replacement. Like intestinal fistula, where you need burn patient, you need replacement therapy because they are losing a lot of their fluid and electrolyte also. All the fluids which are containing electrolytes, the composition of the electrolyte should be very close to the normal plasma electrolyte composition. Like sodium is the main cation. It is 135 to 145 milliequivalent per liter, and anion, the main anion is the chloride, 95 to 105 milliequivalent per liter. The concentration of the potassium is very low in extracellular fluid. Which is a 3.5 to 5, and the potassium is 2.5 to 3. This is the composition of the electrolytes present in the normal plasma. The main two components which are cations are sodium and potassium, while the anions is the chloride and phosphate in extracellular fluid. And the fluids which are recommended for infusion, their composition is very close to this composition of the plasma. As the fluid and electrolyte therapy, two indications are there: maintenance or replacement. Mainly the maintenance and the replacement. In maintenance, it meets the daily balance in order to give patients the to meet the daily requirement, patient's daily requirement, which patient cannot take orally. For example, those patients who are in ICU and in coma, and otherwise, other the replacement therapy, that means the ongoing losses. As I told you, in post-operative cases or even during surgery, if patient is losing a lot of fluid and a patient of burn, a patient who is having intestinal fistula post-operatively, or a patient is having diarrhea, vomiting. These types of patients certainly needs replacement of the ongoing losses, and they must need fluid and electrolyte therapy put together. Not only water, they must need electrolyte also. Maintenance replacement of urine, insensible and insensible losses. There are two types of losses. Those losses which can be seen by our naked eye, like urinary losses, losses in the vomiting, losses in the diarrhea, and another is the insensible losses, the losses of fluid through the skin, in respiration, and in the stool. These are the insensible losses, and these losses must be replaced daily. If patient can take orally, he can take orally in order to compensate the losses. Otherwise, you have to give fluids intravenously to replace these insensible losses. And these are 1 to 2 liters per day. And the electrolyte, to note, the most important are the sodium and potassium. And then daily you must need 1 to 3 milliequivalent per kg per day is the sodium, and as far as potassium is concerned, it is 0.5 to 1 milliequivalent per kg per day, or 20 milliequivalent per day. How to calculate the maintenance doses? If you are going to give replacement therapy, you must know how to calculate it. It is calculated on the basis of body weight of the patient. 4-to-1 rule to calculate hourly rate. Every hour you can calculate it. 4-to-1 rule. 4 ml first 10 kg, 2 ml next 10 kg, and 1 ml per hour for the rest of the kgs. In 1 hour, a patient need how much need? 4 ml per kg for first 10 kgs, and 2 ml per kg for next 10 kgs, and 1 ml kg for remaining kg. This is one method. The other method is 150-20 rule. This is another rule. Whichever you want to, you can calculate you will get the same amount of requirement. In the 150-20 rule, in one day, this is uh, 4-1 rule for the hourly requirement, and this is for the daily requirement. You have to multiply in 4-1 into 24 hours, while 150-20 is for the result is for daily requirement per 24 hours. In one day, a person needs 100 ml in 150-20. What is 100, what is 50, what is 20? Now I'm going to explain you. 100 ml per kg for first 10 kg and 50 ml per kg for second 10 kgs and 20 ml for remaining kgs. Remember to divide by 24 for hourly rate. If you want to, this is the daily requirement. As in 4-1 rule, it was hourly requirement and it is a daily requirement. And if you want to divide it into 24 hours, you must divide the total amount of fluid which comes after calculation. You must divide it by 24 and you will get hourly rate of replacement. What are the types of fluid you have? There are two types of categories, crystalloids and colloids. Crystalloids are the solutions of small molecules in water. The main is the sodium and chloride and Hartmann's and dextrose. Main is the sodium chloride, which is very widely used. It is called as normal saline. It has got a very close composition with the plasma, electrolyte composition with the plasma. And the other is the Hartmann solution or Ringer lactate or dextrose water. These are the three most popular solutions which are used for replacement. The other is the solution of the larger organic molecules, the albumin and jellyfendan. Jellyfusin. Colloids are used less often than the crystalloids as they carry a risk of anaphylaxis, and research shows that colloids are superior in initial fluid resuscitation. Crystalloids are superior in initial fluid resuscitation. इसको मैं दोबारा कर देता हूँ, ठीक है? ये वाले जैसे मैं उर्दू बोलूँ ना, समझिएगा टाइप्स ऑफ फ्लूइड का दोबारा करना है. IV fluids can be categorized into two major groups: crystalloid and the colloid solutions. And the crystalloids are the most popular one, and which you are using in your daily routine practice. And there has got small molecules in water like sodium chloride, which is commonly called as normal saline. Its composition is very close to the normal saline. And Ringer lactate or Hartmann solution, this also has got the composition very similar. It contains the electrolytes and water also. And in sodium chloride, electrolytes and water both together. And in dextrose, it only contains water and glucose in the form of dextrose. It doesn't contain any electrolyte. Usually it is given to the patient where pure water deficiency or just to maintain the IV line. And colloid solutions of large organic molecules, colloid are the larger organic molecules, and examples are the albumin and jellofusin. Colloids are used less often than the crystalloids. Crystalloid solutions are very popular and they are very widely used in the hospital and the clinical practice, as they carry why colloids are not superior than crystalloid, because they are expensive, number one, not frequently available, expensive, certainly needs expertise and certainly needs in the supervision of uh, expert or a proper hospital where they can give to the patient, because they have got a risk of anaphylaxis. That means the reaction can be suspected in these types of crystalloid solutions. And research says that the crystalloids are superior as compared to the uh, as uh, as compared to other solutions like colloids in initial phases of fluid resuscitation. Sodium chloride, as I told you, sodium chloride is the most popular. It is very, its heterozygous, a very close composition with the plasma. Uh, it is isotonic. That's why it is called. It is supposed to be isotonic extracellular fluid, and it is it can be given in the treatment of isotonic extracellular dehydration and the treatment of sodium depletion. Sodium depletion is there. This patient is having deficiency of sodium as a result of, for example, in heat stroke, you must need sodium replacement, or patient is having vomiting, uh, patient is having diarrhea, you must need replacement of sodium and potassium as well. It is a vehicle or a diluent for compatible drugs. You can give drugs with the normal saline in a diluted form parenterally. Another form of sodium chloride is 0.45. The previous one is 0.9, and it is called as half strength. It is the half strength of the sodium, and indicated in the treatment of hypertonic extracellular dehydration. Hypertonic extracellular dehydration, uh, it is a in which this sodium component is already higher, but uh, you cannot avoid the sodium because daily requirement, you must need daily requirement. If you are replacing the sodium, replacing the fluid, you must need sodium also along with it, but not in 0.9%, because already sodium is there and patient is only losing the water. Uh, in these types of situations, half strength, it is called as half strength sodium chloride or 0.45% sodium chloride. It is indicated in hypertonic extracellular dehydration, while the 0.9% 0.9% sodium chloride is indicated in isotonic dehydration. It can be used as a vehicle or diluent of compatible medical products. There are two types of wrinkle lactate solutions, and wrinkle lactate is a solution which has got a very close composition with the normal saline, but it contains lactate. Lactate is it breaks up into bicarbonate, and it provides, in cases of acidosis, it is a very valuable solution in cases where kidney is compromised and as, or because of some other situations, if acidosis is there, the ringer lactate would be the choice. But you cannot use it in the in those places where liver is damaged, hepatic encephalopathy, because lactate breaks into the liver, and if liver is damaged, it cannot break. There is no other way to break it into bicarbonate. So you must be careful while giving ringer lactate. If patient is having hepatic encephalopathy or any other disease of the liver where liver's function is compromised, you must need only ringer. You can get ringer lactate without you can get ringer solution without lactate. So you have got 5% dextrose in lactated ringer lactate solution, or 5% dextrose alone, or a ringer solution alone without lactate. Always remember, be careful when you are giving all these solutions. If sodium is very deficient, you can use normal saline. If deficiency is not so severe, you can give ringer solution. If acidosis is there, you can add lactate solution in the ringer, where you can get ringer lactate. And if you want to give some nutrition to the patient also with the electrolytes and lactate, you can use 5% dextrose in lactated ringer solution. This solution is very helpful if patient is having need energy in the form of glucose and he is acidotic and he is having proper functioning liver or associated with a compromised kidney or some other problem which may lead to acidosis and also electrolyte imbalance. This is a very valuable solution. This is also used for resuscitation after blood loss due to trauma and surgery. And in this situation also, patient is suffering from acidosis and electrolyte imbalance and fluid loss. This is the ideal solution in this type of situations. And also in pancreatitis or major burns. It is in burn is also patient become acidotic and the patient is having loss of lot of fluid and electrolyte. Ringer lactate would be the choice, but not in the electrical burn, because in electrical burn lot of potassium is there and ringer lactate contains potassium. So you be careful when you are giving replacing the fluid in a patient who is suffering from electrical burn, because the muscles are damaged in electrical burn and the potassium level is quite high as compared to other injury persons. And also in trauma patients where a lot of muscle damage, they may also have raised potassium level as a result of damage of the muscles in the trauma. So be careful while giving ringer lactate. The patient may not have raised potassium level as in cases of electrical burn and trauma patients where muscles are damaged and liver is compromised and patient is having mild functioning or compromised functioning liver. So you must be careful while giving ringer lactate in these types of patients. Normal saline or half a strength normal saline, 0.45% normal saline would be your choice in these type of cases. Hartmann's solution is a clear solution of sodium chloride, potassium, calcium, and it contains lactate 60% in water. And it has got this almost same composition with the ringer lactate, but Hartmann's solution is the solution which contains lactate. And later on, the Initially, Ringer was a solution with a composition which is nowadays available, but it doesn't contain any lactate. But later on, Hardman solution were introduced in which lactate was introduced in order to compensate the acidosis. The, the lactate, as I told you, used as a source of bicarbonate in the treatment of mild to moderate metabolic acidosis, sometimes associated with dehydration, sometimes associated with potassium deficiency, sometimes associated with trauma, or sometimes in burn patients, not the electrical burn. In these patients, bicarbonate is needed in order to treat the metabolic acidosis. And if a patient is, if you give normal saline to the patient, you must need bicarbonate uh, along with the normal saline. But in this case, lactate is there that converted into bicarbonate, and patient, you don't need any supplemented bicarbonate along with this type of solution. Jello fusion is a solution, intravenous solution. It is a colloid solution and treatment of relative and absolute hypovolemia and shock. Prophylaxis of hypotension caused by relative hypovolemia during induction of epidural or spinal anesthesia due to imminent significant blood loss. If significant blood loss is there and you have got this type of gel, so jello fusion would be the choice because it is a higher molecular weight, it may retain the fluid, and you don't need to give supplement water along with this. Uh, Procedures involving the extra corporal circulation as a component of priming solid fluid in combination with crystallite solution. Heart lung machine where you can use it along with the uh, crystallite solutions also. Albumin, restoration and maintenance of the circulating blood volume, where volume deficiency has been demonstrated and use of a colloid is appropriate. Because albumin is very expensive. To usually used for replacement of the um, loss of albumin, especially in cases of burn, you can use it and as in order to compensate the loss of albumin, because a lot of plasma is leaking through the vessels in burn patients. In major burn patients, you one must need human albumin in order to compensate the loss, and although it is very expensive, so it is not frequently used to restore the circulation. Usually, crystalloids are used to compensate the circulatory losses. As far as economy is concerned, and the most important crystalloids which are used is normal saline and finger lactate. As I told you, you must need proper information before giving all these. And as far as the jelly fusion and the albumin are concerned, or the high molecular weight other products are concerned, you may have chances of anaphylaxis also in these, and they must be given in the supervision of a experienced physician, uh, or otherwise you can compensate the circulation if you have, if it doesn't have any facility of getting albumin or the albumin like products, you can compensate the deficiencies with normal saline and ringer lactate. They both are very valuable solutions for the compensation of the deficiencies of circulatory volume. Thank you very much.